Hello everybody, welcome back to drug exam number 11. This is a group of medications that they have kind of similar functions. They're to sedate people. We're going to talk about some things that will help reduce intracranial pressure. But this is several medications that really didn't have a home by themselves, so we kind of grouped them all together. The first medication we're going to talk about today is droperidol. Droperidol is also known as Inspacine, and it is a medication that is an antipsychotic, also has some antiemetic properties as well. This medication is typically given IM. There is an IV dose, 2.5 milligrams slow IV, or 5 milligrams given IM. Now, typically in a situation where we have to have a sedate a person who is having a behavioral emergency, they're not going to be overly interested in allowing us to start an IV. So we're probably going to have to give that medication in another route, and we would do that via the IM injection form in the thigh or in the deltoid, ideally the thigh. That is we have several of those medications we're going to talk about in this lecture. The next medication we're going to talk about is Haldol. Haldol is also known as haloperidol, and it is also an antipsychotic and a tranquilizer. Usually these first two medications are used interchangeably. Usually you don't carry both of these medications on the ambulance, but they have very similar effects. The difference with this one is that the dose is different. It's a 5 milligrams IV or 10 milligrams given IM. Like I said, more than likely we will be giving this IM over IV because, like I said, usually the patients that are having behavioral emergencies, they vote no on the IV. Next medication we're going to talk about is ketamine. Ketamine is a very popular medication that is seen in EMS now, and it's given for many, many things. We're going to give it in this situation. What we're going to talk about is as a sedative. Someone who is having an emergency where we need to sedate them, or if we're going to use it as a induction agent to sedate someone before we go with drug-assisted intubation. Now, this medication is a very strong medication. This medication does have kind of, what do I want to say, reputation. You are either in one of two groups. You really love ketamine and you give it for everything, or you're very cautious about it overall. There's lots of stories of problems with ketamine in the news over the past 5 years, but it does have a lot of benefits in the pre-hospital setting. The onset's really quick. It only has about a 30-second onset. It can be given via IM or IV, and typically the dose is 1 to 2 milligrams per kilogram IV over 1 to 2 minutes if we do go the IV route. Now, the truth is that these dosages vary widely. Some places will have you give 500 milligrams to a patient IM, and that's a lot of medication. So other agencies might start at 250. Some agencies will go with the 1 to 2 milligrams per kilogram, and it just all depends on your local protocols. But remember, ketamine has a strong sedative effect. So we have to watch closely for respiratory depression. Unfortunately, one of the things that is a detractor for ketamine is we don't have a way to reverse the effects. Like if we give someone too much fentanyl, we can give them Narcan and reverse the effects of that overdose of fentanyl. But we really don't have that with ketamine. So we don't have that parachute. we might call it, as a way to bring someone back if we do cause too much respiratory depression. But it's a very, very great medication when given in the appropriate doses. But overdose can be something to worry about for sure. Next medication we're going to talk about is Versed. Midazolam is the other name for Versed, and it is a medication we give frequently for sedation, uh, um, for behavioral things. We also give it for conscious sedation if we're going to cardiovert somebody and they're hemodynamically stable. Now, there's a difference between hemodynamically stable to where we need to cardiovert and uh, hemodynamically stable to where um, they need sedation. So I'm not saying that we should be cardioverting a stable patient. I'm not saying that. We do not cardiovert stable patients. That's something the hospital will do with a lot more assistance than what we have out in the world with just you, your partner, and a truck. But so this is for a patient that we do need to cardiovert and we have the IV established. We do have time to sedate them because cardioversion at the end of the day is painful. And if we can help them deal with that via the use of Versed, we want to do that. Now, in this situation, we're talking about it as a restraint, and we're going to give 5 milligrams either IV, IM, or intranasally. This patients need to be stable, though, hemodynamically. And the reversing agent for benzodiazepine is romazicon. We don't see that a lot in the pre-hospital setting, but the benzodiazepines do have a reversal agent that can be used. The next two medications we're going to talk about, one's really a medication, one is really IV solution, are given for patients with an increase in intracranial pressure. Now, intracranial pressure. How do we identify intracranial pressure? We need to be looking for Cushing's triad. Let's remember back, what are the three components of Cushing's triad? Cushing's triad is the presence of widened pulse pressures, or some people refer to it as hypertension. We see different types of respiratory irregularities. So I don't get too hung up on Cheyne-Stokes or Kussmaul or Biot respirations. If you have irregular respirations, that's good enough. You don't need to identify which type of um, uh, respiratory irregularity it is. What you need to identify is that there is irregularities in the respiratory pattern. So that's two. And the third is bradycardia. Now, bradycardia in the pre-hospital setting is not as prevalent as the other two. Usually, if someone is in a state of Cushing's triad in a pre-hospital setting, there's a lot going on. They have some sympathetic uh, uh, response to whatever the event is. So they tend to have a little bit of adrenaline. They tend to have a catecholamine release, and their heart rate seems to be a little bit more in that normal area. But the classic third component of Cushing's triad is bradycardia. Now, when we have those three things, really, if we have the two, if we have high blood pressures, widened pulse pressures, either way you want to call it, and irregular respirations, that's good enough for me. That's Cushing's triad. And we need to think about that. And when we see Cushing's triad, the big concern is with herniation. Herniation of the brain, that pressure that's pounding on that brainstem, that's going to cause those respiratory irregularities. And if we don't do something about them, or do something about that, the patient's going to have a very poor outcome neurologically and probably will succumb to that injury. So what we use mannitol for is to diurese the patient, When we diurese the patient, remember, it is something that makes the patient diurese, causes them to get rid of fluid. And that fluid can be drawn out from those brain cells that decrease of the fluid inside of those cells in the brain will cause a decrease in the pressure. And it's a very, boy, I won't say last ditch effort, but boy, it's really a bad situation if we're to the point where the patient has so much in the way of Cushing's triad that we need to start thinking about pulling fluid off of the brain. The dosage for mannitol is 0.5 to 1 grams per kilogram IV given over about 30 minutes. And hopefully that will lower the intracranial pressure. The last medication we're going to talk about isn't really a medication at all. It is an IV solution. And what it is, it's 3% sodium chloride, a hypertonic IV solution. And I want you to think about this from the point of normal saline. What we know, we're more familiar with normal saline. Normal saline is also called 0.9% sodium chloride. And so when you think of 0.9 versus 3%, this 3% sodium chloride is has 3 times more sodium content in it than the normal saline. So there's a lot of salt in it. Remember, normal saline is kind of like your tears. It's remotely salty, but it is not an overly salty fluid. Now, with the 3% sodium chloride, it is very salty. And what do we remember about sodium or salt? Water likes sodium or salt. So the idea behind giving 3% sodium chloride is to use osmosis to put a lot of salt into the circulatory system, and those brain cells that are swelling and have fluid inside of the cells, that fluid is going to see that sodium going by, and that sodium is going to draw that fluid out. When it draws that fluid out, those individual brain cells are going to get a little bit smaller, and that little bit smaller will help reduce the intracranial pressure, and hopefully we can stave off that herniation that is going to be so dire for our patient. Now, really, 3% sodium chloride should be given through a central line, and the infusion rate is really dependent upon the situation. I would refer to your local protocols or contact medical control. And this patient, if a patient is hypotensive, we really should not be thinking about giving 3% sodium chloride. Now, this is some places will do this, other places won't. Please refer to your local protocols for this, and this is just a general explanation of 3% hypertonic solution. As we get further into class, we will talk about hypertonic, hypotonic, isotonic IV solutions and what they are specifically for and how we specifically use them. Now, that's it for this lecture. If you have any other additional questions, please reach out to your instructor, and I hope you have a wonderful day.